طبعا انتوا تعبانين وزهقانين ويوم طويل، بس انتوا لا تتخيلوا سعادتي يعني انا في اسكندريه مع دكتور في اسكندريه. طبعا دكتور سعيد كامل بيحب دايما يحكي الهيستوري، والهيستوري ان احنا ابتدينا برياتريك سيرجري سنه 96 في مصر، وبعدين كنت انا وبعديها علاء وعصام عبد الجليل وهاني نوره، وبعدين اسكندريه توك اوفر جم شافونا مره وخلاص كانوا البرياتريك سيرجري في مصر وهم بيعملوا اكثر اعداد واكثر كل حاجه، طبعا دي حاجه احنا نسعد فيها. طبعا انا هنتكلم عن الريفيجنال بارياتريك سيرجري وانا ما عنديش اي ديسكلوجرز لازم نقول لو لنا الشركات بتصرف علينا ولا حاجه، للاسف لا. الصوره دي لطيفه جدا بعرضها كتير، ابني صورها لي في معبد الاقصر. طبعا شايفين فوق راسي في اله الخصوبه الفراعنه، ولو بصيتوا قريب هتلاقوا ان هم راسمين السبرم من 5000 سنه زي ما احنا بنرسمه تحت الميكروسكوب النهارده. يعني لو بص السبرم هنا ده الفراعنه رسموه بالطريقه دي من 5000 سنه، مش معروف ازاي. ماي كيس ميكس ديسكلوجر ده مهم قوي في اول محاضره تعرفوا انا بحب اعمل ايه عشان تفهموا البايس اللي عندي. انا 70% من شغلي ريفيجنز، ومعظم شغلي باي باسز اللي هو ماي جاستريك باي باس، وكل الحالات اللي بعملها بحط فيها باند، لو سليب هيبقى فيه باند، لو باي باس هيبقى فيه باند. فانا راجل بايس جدا ما بحبوش على كلامي. Do you know that on average humans have one testicle? This is a scientific fact. Do you know that? It's a true fact. Humans دول men and women. ما اعرفش مش فاكر عنه المعلومات المختلفة. وكل واحد بيبص اللي جنبه طبعا. ان هي this is a true statistical fact عشان humans are men and women. بس انت تقدر تبلاي around the statistics وتغير statistics في شغلك وتقول اي كلام ويبقى شكله صح. يعني misinforming people by the use of statistical material is called statisticulation, statistical manipulation. The blackest lie is a partial truth that leads you to the wrong conclusion. This is a very bad paper that I've witnessed. أنا مشكلتي في البارياتريك سيرجري إن أنا حاولت في الإبسو من 20 سنة إن إحنا نعمل دوكيمنت على how to report our results by standard techniques. لازم كلنا في الليترشر نقول percentage excess body weight loss، نقول نفس الأرقام عشان لما نقارن results نبقى نقارن apples to apples. الستادي دي معمولة بناس مشهورة قوي منهم طبعا جاك هيمبنز الوحش بتاع بلجيكا وناس المفروض ان هي محترمه، طبعا هي مش محترمه قوي يعني، لان هم في الريبورتنج بتاعهم عشان تجستيفاي اليوز بتاع اللاب باند بيقولوا ان انت you can have good results لو الويت لوس بتاعك 31% excess body weight loss. وهو اللاب باند لما ابتدينا نشتغلها was a very bad operation، بس they continued doing it by playing around with statistics. So they say if you lose 30% excess body weight loss, it's a good outcome, which is bullshit. So this is a classic example of statisticulation. My work in Egypt started in 1996. This was the open bariatric surgery era. At that time, we used to do all open techniques, BBG, gastric bypass, BBD, and we used to do a 20-minute BBG with a 5-centimeter incision, which is quite comparable to what we do in laparoscopy now. And this was the first publication I published in 1999 in obesity surgery. It's about this 5-centimeter incision. By the way, this is the first patient I did in Egypt in 1996. He was 200 kilograms. He went down to 80, and up until today he's still 80 kilograms. And his daughter married, and she now became morbidly obese, and she needs surgery. So sometimes BBG works for a long term. طبعا مش big percentage, but it could be a good operation. This slide, they had in New Delhi a conference trying to standardize bariatric procedures, and this shows how many procedures we have. And this tells you one thing: we don't have one good operation, because if you have one good treatment, it will cancel all the others. So if you have so many treatments for one disease, that means none is effective. I was wrong. Those words separate scientific pros from posers. When you receive the PhD, a chemical is secreted in the brain that prevents the recipient from ever saying, I don't know, I was wrong. The process of critical feedback is the lifeblood of science. It doesn't matter who you are or how important you think your idea is. If it's contradicted by evidence, it is wrong. Pseudoscientists typically eschew peer review process to avoid inevitable critical commentary, and that's an integral part of the healthy science. Smart people believe weird things. This happens all the time, and this happens because of confirmation bias, because we already know. This is something that happens very frequently in medicine. It's a natural tendency to accept evidence that confirms what we already believe, to accept facts that only strengthen our preferred explanation, and dismiss data that challenge what we already accept as truth. And we all have inherent and natural tendency to search for evidence that already meshes with our beliefs. So I hate sleeve gastrectomy. So whatever I hear bad about sleeve gastrectomy is a good publication, and I hear it. Anything that is said good about sleeve gastrectomy, I don't believe. So it's the nature of confirmation bias itself to dismiss all contradictory evidence as irrelevant. So my evidence is always the rule, your evidence is always a mistake or an exception. And this, as we discussed earlier today about one anastomosis gastric bypass and an internal hernia. So if you want to keep on doing one anastomosis gastric bypass, you will always disbelieve that it causes internal hernia. Zero bias, good luck finding it. Zero bias is a myth and an illusion. Nobody is really unbiased. And this is a simple diagram of table for the success percentages of procedures over time. This is a very old diagram, BBG, ROI, banding, and BPD. And as you see, things at 2 years look very good, but not perfect, by the way. So if you have 50% success at 2 years, that means you have 50% failures. And at 10 years, the picture completely changes. So at 10 years, you have much less success rate and you have much higher failure rate. Because if you put the same numbers in reverse order, these are the failure rates at 2 years, and these are the failure rates at 10 years. If you're talking sleeve gastrectomy, I believe, which is probably wrong, that 80% of the cases at 10 years would have failed the sleeve gastrectomy. So what are the complications, obstacles that we have nowadays? We have no breakthrough in bariatric surgery techniques. We are officially in the post-procedure peak. So what now? We have no proper patient follow-up and poor long-term data, rationalization and failure explanation, as I showed with the 30% success. Bariatric honeymoon abuse. Every bariatric procedure will give you a good result 1 to 1.5 years. And fantasy procedure creation has started. So we do now animal experiments on humans. This happens with the chassis and Susu, Sisi, Sasa. Everybody is trying to make an operation. They name it after himself. And also the explosion of bariatric surgery industrial design business model. So this is started in Jordan with the surgeon doing 40 sleeves per day. And this surgeon is only aiming for money, very low price, budget, operations, 5 operating room, everybody's preparing the stomachs for him. He's just doing the stapling part, and 0 pre-operative, 0 post-operative follow-up, and patients die because of this practice. So this is good for Coca-Cola factory, but not for human science. What is the mechanism of action of bariatric procedures? We don't know. We think we know. Is it restricted? Is it malabsorptive? All the theories change with time. Now they're talking about hormonal. So it's not restricted. The bariatric procedure is not restricted because it produces incretins and decreases anti-incretins, and this is a hormonal effect. We have 0 evidence that these hormonal effects last. We have 0 long-term data on hormonal changes of bariatric surgery, whether they maintain or not. And if you think of your patients cannot eat for the first year and a half, and then they become hungry. So the Karelian theory is gone, and GLP-1 theory is gone, and then they start to gain weight. Also, they postulate other theories like biosalts, gut flora, etc. And this is how we design a bariatric procedure. So we do a pouch, and the size of that pouch differs very much because you can have a small pouch gives you good results, and you have a big pouch with the same operation very bad results. The size of the anastomosis, if you enforce the pouch with a band or not, elementary limb length, peripancreatic limb length, common channel length, all these are variables involved in constructing one procedure. So you can have a room-wide gastric bypass with zero weight loss because you had a big pouch, big anastomosis, no enforcement with variable limb length that did not produce the desired weight loss. And what is the problem of the design elements that we have is that they change with time. So if you have a restriction initially, it goes away. If you have malabsorption with short bowel lessons, everything goes back to normal. If you have hormonal changes, they might go back to normal. So to have an operation, and this is very sad, when you give the patient an operation, the patient cannot eat, cannot drink, and loses weight for a year and a half, and then they start eating and drinking and gain the weight. And then we blame them that they did not change. So we give them initial help, and then we took it away from them. And the honeymoon, as we discussed earlier, so all bariatric procedures will show some weight gain after the honeymoon, and results 5 to 10 years will be completely different from initial results. Even the SOS study, they have a full long-term follow-up. They show this with all procedures. Also, the dilution effect of honeymooners, because if you do 100 cases in the first year, 200 cases in the second year, 300 cases in the third year, at the end of the third year with 600 cases in your series, you have only 100 patients that failed. So you have 85% success, or you can have 100% failure, because these are the first 100 you did. So you should stop recruiting patients to your series to know your results. Keep doing the cases, but don't count them in your results. And also the laparoscopic explosion that happened in the 90s, lap band happened in 1993, was very attractive because it was the only laparoscopic procedure. Whitgrove and Clark did the laparoscopic room wide, and they kept that secret, and they didn't let anybody see the operation so that nobody would know how to do it. So everybody was searching for other techniques. So Rutledge did in 1998 one anastomosis gastric bypass, and the only reason for why he did that is that he was technically not capable of doing two standard anastomosis and gastrogenostomy, so he did one anastomosis and said that's enough. He was following his patients by internet. He never had physical follow-up for his patients. He published his 5-year results with zero follow-up that he didn't mention. So he never followed any of his patients, and he gave very good results. Laparoscopic duodenal switch started with Michel Gagnier, who is a macho surgeon who has a very big surgical skills, but he was always criticized because he never followed up his patients, and he was very busy doing weekend courses. This is probably most of you did not attend this time of the development of bariatric surgery. So it's always important to know the history, how things started, because when we forget the history, we tend to believe the lies that we see in bariatric surgery. And also the phenomenon of fanboys. This is very common in bariatric surgery. It's an extreme fan or follower of a particular medium or concept is known for complete lack of objectivity in relation to their preferred focus, and they are known for using the phrase object of affection is the best ever. And to them, opinions are facts. And the third thing is the fanboys don't realize that these companies that fuel their passion don't really give a damn about it. So a fanboy is an arrogant person who goes on an outburst every time something he likes is questioned. Fanboys usually accuse others of being fanboys. So like these guys, they're fanboys of Star Wars. You see this guy, how he looks? Very similar. So they started to do single procedure conferences to justify their data and results. What is a single procedure conference? It's a sleeve gastrectomy consensus conference where 100 sleeve lovers gather together and get a consensus about the procedure. And this is completely unscientific. And this is a confirmation, a fanboy conference or a confirmation of bias conference. It's a conflict of interest conference. Pseudoscience of the present. Let's discuss some issues now about sleeve gastrectomy. It started as a first stage procedure, then became a definitive procedure as many patients did not have second stage. They didn't come back. And with the pseudoscience that is said, it's a simple operation, no vitamins. We don't change the GIT physiology, and effects are due to hormonal changes are not restriction, and has good results. And the reflux issues are not important, we just ignore it. And sleeve gastrectomy treats esophageal reflux according to some authors. So this is no science, because as you see here, the progression of doing sleeves, this is a sleeve gastrectomy, this is a Magen-Straza operation. This started in 1992 in England, and this has failed and completely disappeared. It's a sleeve. It's a reversible sleeve. So they do the sleeve, and then the sleeve dilates, and the patient gains weight. And this is exactly what happened here. But here we have a longer follow-up, so the operation has disappeared. Here we're waiting for that longer follow-up for the operation to disappear. The science about sleeve gastrectomy, it's a radical operation. It's a 90% gastrectomy. It's the only irreversible procedure in bariatric surgery. Similar procedures like the Magen-Straza ultimately fail because of the longer follow-up, and ultimately the stomach will dilate, weight regain will happen, and it is a reflux-inducing operation. So you should tell your patient it's a reflux-inducing operation. So think about what we're telling our patients now and what we should tell them. And then they try to do sleeve, add things to the sleeve to make it more powerful, like an adjustable band, non-adjustable banding, and they go smaller with the bougie size. We had this comparison this morning, and they started with the bougie of 60 with the duodenal switch and went down to 32, and now they're doing probably 36 to 40 is the most accepted. And actually they do a re-sleeve gastrectomy, and this says a lot about people that say sleeve is not a restrictive operation. So if it's not a restrictive operation, why are you sleeving your patients? So the definition of sleeve gastrectomy: irreversible reflux-inducing radical gastric resection that gives temporary gastric restriction, and this is what we should tell our patients. I used to sit with the duodenal switch group in the 90s in the ASMBS, and I used to open a door, and I find myself sitting with Hess, Morceau, Nicolas Copenaro, and Setubal Sar. I was just a new kid on the block, and this was very amazing to me. I see all these icons. And actually what I've seen with them is that everybody is doing the operation in a different way, and every year they are changing the design of the operation. And in the 90s I did a lot of duodenal switches, open surgery, and they failed. So I had failures with duodenal switches, so I find it very hard to swallow to tell you that sleeve alone would succeed. Balthasar was the most honest of them, and I see Balthasar every year. His bougie size is getting smaller. His common channel, he was, at the end, before he retired, he was doing a common channel of 60 with the duodenal switch. So that tells you something. It's not what we see in literature. This is what we have on the IFSU website. Disadvantages of sleeve gastrectomy surgery: potential for higher for inadequate weight loss, potential for dilatation affecting the weight loss, and considered investigational by some surgeons. Consider temporary treatment for obesity unless second stage is performed. So this is what we still have on the IFSU website until today. So why would you place a band on a sleeve? We had some good scientific studies that did prospective randomized studies and compared the outcome of doing a banded versus non-banded sleeve. And at 5 years, the results for the banded sleeve was much better. Why do you put a band on the sleeve? Because sleeve will ultimately dilate, so if you put a band, you might limit the ultimate dilatation. Also, if we talk about the one anesthesia gastric bypass, the conclusion was that one anesthesia or mini gastric bypass does not cause alkaline reflux, has better weight loss than Room Y, was written before starting the experiment. So Rutledge was sitting in the SMBS saying it's a better operation than Room Y without comparing it to Room Y. So he did that conclusion, and this is very common. You do the conclusion and then write the scientific. And they always have unproven explanations. So they say it's a long pouch, so that's why we don't have reflux. And weight loss is because it's a matter of long operation, even though they don't measure the common channel measurement, which is the determinant of the malabsorption. And it's better. I was chairing a session in Paris, in Paris, with Rutledge, who was presenting a paper saying mini gastric bypass is better than Room Y gastric bypass because he sends his patients home next day, and Room Y, the literature says they go after 3 days. So mini gastric bypass was a better operation. I told them my redos go home after 6 hours, so does this make it a better operation? And they started to manipulate the media, misinforming the patient that it's better without comparing. And the pseudoscience, they started to speak about minor fat absorption in room-wide gastric bypass versus major fat absorption for leak. And if you have a leak in a smaller pouch, it's because you didn't do the operation their way. And their complications, they always say it's not my NGD. So as I told you, no patient follow-up, just internet, and he published 5-year data. And science with evidence-based medicine, that this happened with Dr. Lee. Dr. Lee did a comparative study comparing room-wide versus mini gastric bypass, and he said they're the same, even mini gastric bypass is better. So let's stop here for a minute and see the history. Who are we following? So Rutledge, the guy his license was cancelled in every state in the United States, and he is not allowed to practice surgery in the United States. He is publishing without following up his patients and saying, I have very good results from my data. And now he's partnering with his friend in India. And the second one that did the study that seemed scientific, Dr. Lee. Dr. Lee, do you know that he was imprisoned on fraud and bribery charges? He was in prison, he served sentence in prison. So this is one of the most common procedures done in the Middle East, and we are following 2 scientists for that, and they are both crooks. The facts are اللي كان هيمسكوه رئيس نفسه وبعدين شالوه وراجعوا كل البيبرز صح. So the definition of one anastomosis gastric bypass, it's a big pouch, single anastomosis, alkaline reflux, and anastomotic ulcer inducing. Slightly restrictive, maybe malabsorption gastric bypass, where surgeons don't care about the common channel measurements, which is the malabsorption extent determined. So if we say we don't have alkaline reflux, this is wrong. We have 100% of our patients have 8 liters of alkaline secretions passing by the stomach every day. So whether this is clinically significant or not, this is something else. But 100% of the one anastomosis patients have 8 liters of alkaline secretion going through the stomach every day. And it's well known that if you have a bigger pouch, the bigger the pouch, the more the acid, the more the anastomotic acid. So the big pouch will dilate with time, patients will consume more calories and probably will gain weight. Big pouch, more acid, more anastomotic ulcers, and one anastomosis equals alkaline reflux in all the patients. And now they started to make up data. So this is his 6-year study in 2,410 patients that he never followed. And now they're trying to start making science. And do you see this? Non-obstructive restriction of one anastomosis bypass. And the perfect deception in bariatric surgery is when you have an easy procedure, short-term success, long-term, who cares? If you have failure, just blame it on the patient. The patient is not compliant. And this is the era of bullshitization in bariatric surgery. This is the era where bullshit is replaced true science. The bullshit artist. Honesty, for the most part, is less profitable than dishonesty. Genius is the ability to produce fantastic amounts of equally fantastic bullshit that all makes sense. When someone wants to align with their point of view to get you to buy their products, they will talk passionately about all the positives of their offering or ideology. They omit the downsides, and they will, while appearing to be respectful, bash every other view that does not confirm with their agenda. If they have the resources, they will rely on testimony of experts just to drive all the points at home. And this is very frequent when you see it when you are trying to sell a sleeve tissue. So you talk to the patient passionately that you don't change the GIT physiology, and there's no anastomosis, no vitamins, no. That's. Have you heard about the Dunning-Kruger effect? This is a psychological phenomenon that was described in 1999. So it's also called Mount Stupid or Smug Snake. There was a thief that was trying to steal a bank in Canada, and he was so upset that they got him on the cameras, with the surveillance camera, although he put some lemon on his face so that he doesn't show on the camera. So, and the dumber you are, the more confident you are that they are not actually dumb. And they basically, these people are too stupid to know they are stupid. This is my brother. He published 3 books until now. This is the second book that he published about artificial intelligence, and he has a very nice chapter in it, describing who's bad and who's good, the good versus evil game. Who's bad? Americans believe that they're the good guys, while Russia, China, and North Korea are the bad guys. But if you ask Russia, Chinese, and North Korean, Americans don't seem so great. Biden called Russians murderers. Putin replied, America is the only country in the history of humanity to use atomic bombs against civilians. So it's very relative. Everybody believes they are the good guys, and those who differ are the bad ones. No one on the bad guy side feels they are doing anything wrong. And it's not hard to know to do the right thing. It's just hard to know what the right thing is. So how do we report our results? Honeymoon, 2 to 5 years, 5 to 10 years, more than 10 years. True results are after 10 years. Why procedures fail? Obesity is not a GIT problem. All pouches will stretch and dilate. Small bowel will always adapt. Dumping will resolve. Food intolerance improves. Appetite returns. Hormonal changes, if any, come back. And social and cultural pressures remain. Behavioral issues. So if we talk about gastric bypass, if you say success is 50% excess body weight loss, if you talk about 1 million standard gastric bypass performed, 150,000 failures of 2 years, 500,000 failures of 10 years. What is the fate of these numbers, huge numbers of patients? They will either stay morbidly obese, they will have a revision, or will die of old age. So why will the gastric bypass fail? Because, as we said, the anatomy will change. So the small pouch will be big, the stoma will dilate, the jejunum will dilate, patients will consume more calories and gain weight. And this is the concept why we do the banded micropouch room-wide bypass that we witnessed today. So what happens to the bariatric patients in the long term? We don't know. We don't have long-term studies and poor long-term follow-up rates. I follow up my patients for life for free. At 15 years, I have only 40% follow-up. If I publish with these 40%, I will have the greatest study on the planet for bariatric surgery, but this will be fooling patients, fooling people, fooling surgeons, because 40% follow-up is not enough to publish. This gentleman described the micropouch in the 90s, and he did a patency for it so that it will remain in his name. And doing a patency means that you write everything. The guy did a very small pouch, as you see, in the 90s. And he did a roll limb of 200 centimeters, a BP limb of 150 centimeters, and he was attributing his good results to the pouch. And we have recently started to make the BP limbs longer to have better results in bone. Why do we do the banded micropouch? It combines the banding of phobia and the micropouch of sapella, so it's a banded micropouch procedure. So why would the operation fail? Because of inadequate restriction. This is either technical, when you have a huge sleeve in the beginning, or happens in the long term. Gastric fistula development with bone wire is an important reason. Also maladaptive behavior and depression. Depression is a very important cause for pain. Design of bariatric revision procedure, you have to know what is the reason for revision. This is for reflux, loss of restriction, inadequate malabsorption, and the tools you have is to make a smaller pouch, restrict the pouch, restrict the jejunum. Some people add the jejunal sleeve or adding malabsorption. So what do you do if you have a failed revision? Because 70% of my practice are around revisions after. What I see now is I have patients that failed 1, 2, 3, and 4 procedures. So you have to know the anatomy of the last procedure, eating history of the patient, and if the patient is consuming high-calorie products. Because I always tell the patients I can make a tight operation that costs only water, and that water could be a glass with 0 calories, it could be the same glass with 10,000 calories. It's up to you. And also the history of complications in the previous procedure. So, as we said, the contrast study is very important. This case shows the gastric fistula development, and these patients do very well when you divide the gastric fistula. Is it important to be small? It's controversial, but some authors would say very small pouch is not important, but in my practice, a micro pouch, less acid, less ulcers, and less eventual dilatation. Bands in bariatric procedures, these are the extra restriction, prevent dilatation. Also, which size of the band, because at BBC we had a very nice study when they did 5 centimeter, 5.5 and 6 centimeter bands. 5 centimeters had terrible food intolerance, 6 centimeters had failures. So the right size of the band, the right material, not all the bands are the same. Extra restriction is not put in for extra restriction, it's put just to limit the eventual dilatation. And if you hear this, you know that bands are bad because they erode and they cause food intolerance. Well, yes and no. If you use the right size, it's not as common or as problematic. And nowadays, for erosion, we just cut them and pull them with a scope, so it's not a big deal. 99% endoscopic removal rate. Tight bands cause food intolerance, we don't use these. And it's unusual to have food intolerance with at least 2 centimeters in diameter. This is what we call a loose band. Ego is the anesthesia that deadens the pain of stupidity. So my experience with revisional procedures, I've done almost 1,000 procedures since 1996, and 300 of them had more than one procedure. I've done a patient that did 5 previous bariatric procedures, and these are very tough cases and very complicated, and the complications do go very high. Sometimes when you do the right thing for the patients, they are all set. They lose the weight and they have, but as you see, I have 7.5% leak, which is a nightmare to live with, especially when you put bands, you cannot place stents. Because if you put a stent on a band, it will erode. So usually if you want to place a stent, you have to go in and take out the band. And the results are not bad, because we always hear that revision surgery is not, they don't have good results. My results compared to the primary are not bad. They're not very, they're not up to the primary levels, but actually they're not very poor as described in other procedures. So if you do a sleeve gastrectomy that fails and you do a room wide, a standard room wide after that, it usually doesn't work. If you do a one anastomosis, it's not very successful. If you do a small pouch with a band on it, success increases. So my lessons learned after 26 years of bariatric surgery management of failed revision surgery procedures. First thing, you have to learn to do nothing. You have to say to the patient, I cannot do anything for you, I don't have. If you have an intact anatomy and you have a patient that is not cooperative, no matter what you do for him, it's not going to work. I fell into this trap several times, and I have patients with their families signed a mortality consent with them to make me revise the operation without stopping bringing huge amounts of chocolate into the house. And I did 1 and 2 and 3 revisions, and it doesn't work. So unless the patient is cooperative, it's not going to work. Adjuvant therapy has risen as a very, very good alternative. So if we say the mechanism of action of the lumen gastric bypass is partially hormonal, and one of them is GLP-1 increase. So if I give them GLP-1 to a sleeve gastrectomy, a failed sleeve gastrectomy, or a failed bypass sometimes, Saxenda, Victoza, Trulicity, and also treat the depression of that, it works. So my first line of treatment for revision was just to give them the adjuvant therapy, try to change the behavior if the anatomy is intact. Never repeat the same procedure again. So re-sleeves, we had a good study by Patrick Noel that re-sleeve is a good operation, and then he came himself in our conference and said it's not a good operation. So the only indication for re-sleeving, if you have the primary failure, if you have a surgeon that did a huge stomach that did not cause weight loss, you might consider re-sleeving. If you have a patient that did very well for a year and a half and then gained weight after 5 years, and you go in and do a re-sleeve on him, it doesn't work. You have to correct the anatomy, trim the pouch, put the band, and vary the malabsorption component. Also, you can, if you convert to a standard lumen gastric bypass after first sleeve, it doesn't work. Distalization alone for lumen gastric bypass, it doesn't work. It adds the side effects without the weight loss. In our experience, banded micropouch lumen gastric bypass give the best weight loss results in revision of revisional cases. This is a quick video. I thought we might not need it because we were supposed to do a redo case in the morning. But probably it's not going to work. This was revising a lumen gastric bypass into a banded micropouch. Seemingly it's not working. The truth will set you free, but first it will piss you off. I cannot give you a formula for success, but I can give you a formula for failure, which is try to please everyone. Alfred Prosheri is very well respected by Egyptian surgeons. I met him in London a few years back, and he says that there are patients whom we cannot help, but there are none whom we cannot harm. So the conclusion, this is what we have in bariatric surgery, the literature today. Everybody knows. And it's high time. Not high. It's high time. We have to learn to say no. Revisional surgery post-failed revision is feasible at a high cost of high mobility and mortality. Banded micropart trauma gastric bypass gives a very good weight loss and comorbidity improvement, treating failed revision procedures. Logic-defying science is wrong. So whenever somebody tells you I'm going to do a sleeve and it's not going to dilate, this is wrong. It will die. Biases are filters of information. Ego is the enemy of science. Thank you.
بشكر الأستاذ الدكتور خالد جودة على المحاضرة المتميزة دي بصراحة، يعني من المحاضرات النادرة جدا إنها تبقى تدي الداتا بتاعها بالأسلوب ده. I enjoyed it جدا الحقيقة والله يا دكتور خالد، ولو حد حابب يسأل الدكتور خالد يتفضل. المحاضرة الممتعة. باير نعمل ريجستريشن للبرنامج.
سوري ان انا طولت عليكم، بالعكس
محاضرة ممتعة فعلا.
برياتريك اللي انا اسمعها كذا مره، احنا لازم عندنا محاضره طول السنه في الموضوع كده، يعني بنصحي الناس شويه بالواقع والمصيبه لما بيبقى في مس سيلينج. احنا عندنا جراح في مصر الحمد لله قدرنا ننفذه من الجامعه، كان بيطلع في التلفزيون يقول لك انا بعمل باي باس بس ما بديش فيتامينات زي الجراحين المتخلفين بيدوا فيتامينات على الباي باس عشان انا متكلم. فالعيانين كانت بتمشي تروح على الاتراكشن دي وفي الاخر بيموتوا. فحضرتك احنا اي عمليه even sleep gastrectomy they need vitamin supplementation for life. ولما عملنا comparison at 5 years على عيانين خد supplementation ما بين السليب والباي باس، السليب عندهم انيميا اكتر. واحنا مش هنخسر حاجه لما نقول للبيشنتس، يعني انا دايما بقول للبيشنتس هدف البارياتريك سيرجري ان هم to lose weight in a healthy way. to lose weight وهم بياخدوا proper nutrition، مش يبقوا مال نانش ولوز ويت. انا ايام جاي بيشنت 27 سنه في العياده 60 كيلو وجايين على كرسي بعجله شكلهم عندهم 90 سنه. معمول لهم سيفيرلي مال ابزورب وانا سموث جاسيك بايباس ومن غير بروبر فولو اب. بنديهم تي بي ان ونخش نلقى لهم هرمونات بيجوا 60 كيلو وهم هابي وبيجروا ويروحوا ويجوا وميك اب. فاحنا مش اتس نوت اباوت ويت لوس، اتس اباوت هيلثي ويت لوس فور لايف. لازم نبطل نقول للناس ان العمليه اللي انا بعرف عنها احسن، ده نفس اللي بيحصل من المناظير بيقولوا لهم ما تقلوش اعملوا بالون، وبتوع اللاب باند بيقولوا لهم لا اوعوا تعملوا باي باس، اوعوا تقطعوا في معدتكم واوعوا مش عارف ايه، اعملوا لاب باند وخلاص، وحتى لو فشلت نشيلها ولو سخنتوا نعملها لكم تاني.
شكرا جزيلا. نورت اسكندريه وشرفتنا والله يا دكتور خالد.